our work end பண்ணிட்டு we are all on our way home. So this is a monthly webinar planned by Sampath Kumari Madam on the first Monday of every month. And alternate months only Adolescent Committee gets a chance. But this time, because Midlife Committee couldn't do, they've given the chance to us. So actually, I had reserved this month for STI and HIV, which is for the month of December. Because December 1st is World HIV Day, so I thought we'll do this particular CME on leukorrhea, STIs and HIV on that day. But it's all right. We are doing a program now. So I'm really very happy. Now we are coordinating OXY Adolescent Committee and the TNFOC Adolescent Committee together. We are hosting this program, this webinar. Jointly, we are organizing. I'm really very happy that both the committees, Adolescent Committee of members of both the OXY and TNFOC have joined together to bring about this. I now request Sampath Madam to say a few words of welcome to everybody.
Yes, thank you, Dr. Vijay. See, as she was telling, we are conducting in the first month, every month, first Monday, 1 month adolescent and another month menopausal programs. As all of us know, the adolescent are 23% of our population is adolescent, and about the STD cases, 50% of the new cases are in the age of 19 to 25 years. So that's the reason I think Vijay would have taken this topic, leukorrhea and STD. And really, I should thank Dr. Vijay Lakshmi and Josephine for putting effort to make the adolescent committee at the higher level in OXY and the TNFOG. And I wish all the best and success for the webinar. Thank you, Vijay and Josephine and Meena. Thank you.
Thank you, Sampath Madam, for the
All the
beautiful
delegates
words.
and the faculties. Yes, Josephine.
Yes, madam. Now I call upon Meena ma'am, our secretary of OXY, to give the OXY prayer so that we will be proceeding on with the program.
Yeah, thank you, Vijay madam. Thank you, Josephine.
Yes, ma'am.
Thank you, Sampath madam. So now we'll go with the OXY prayer.
Meena, before you start the prayer, can we have the lighting of lamp and then you can have the prayer?
Yes, madam.
Prayer
Sure, madam.
Chitrakala, ha.
So whether it is in person or whether it is a webinar, the symbolic representation of dispelling darkness, which is the lighting of lamp, is carried out ceremoniously. So now we go ahead with invoking the blessings of the Lord. Over to you, Meena.
Thank you, madam. Now we'll move on with the prayer as all the... Am I audible, madam?
Yes, you are audible. Chitrakala, change the slide. Yes.
As any function should start with a auspicious prayer. So we start with the OXY prayer. Can you project the OXY prayer?
Chitrakala.
So I will go with the prayer. Thank you, God. In humility we gather. In gratitude, we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch. To celebrate the arrival of each new life and a mom reborn. The courage to deal with it all when things are not perfect, and to remember that we are but messengers. To keep our women safe and free from sorrow, we bow before your kindness and the magnanimity of your endless love. Thank you. Over to you, Vijay ma'am.
Thank you, Meena ma'am, for taking us through the OXY prayer. And now we proceed on to our first session of the day, where we are going to start with our master trainer, Dr. Shanti Gunasingh ma'am. Chitrakala, can I have the CV slide, please? Okay, Shanti Gunasingh ma'am doesn't require any introduction. doesn't require any introduction. She was the former director of Madras Medical College, IOG, and she has been very an exuberant president of Chennai Menopause Society, very highly active in our Adolescent Health Committee. Now she'll be giving us a talk about uh, on HPV vaccination, which is very important in adolescent age group. So over to you, madam. Thank you so much for accepting our invite and accepting to be a faculty, Shanti madam. Over to you, ma'am.
Josephine Shanti Madam, past president of
President
our
Oxy.
OXY, past
Oxy.
president of WDA. For everything, she is the past president.
Oh,
Yes,
okay.
Shanti Madam. Then
Project
whatever
director
topic we
for
tell, immediately she will accept. If she is in the place, she will accept. Okay, thank you.
And this
Welcome,
particular
Shanti Madam.
topic, she is the master trainer for HPV vaccination. One of the master trainers in our state. So over to you, ma'am.
Okay, thank all participants. Now I will share my presentation.
Your screen is visible, ma'am.
Chandra ma'am, good evening. Welcome, Chandra madam. Hello, Chandra ma'am. Good evening.
Yeah.
Good evening, Vijay. Good evening.
The topic given to me is HPV vaccine in adolescents, and I'm really glad for this topic, as this is one thing which I'm really very passionate about. So this ICMR data from our own place shows unequal toll of cancer on women. So women are more affected with cancer, and if they are cancer afflicted also, the outcome seems to be poorer in women. So it is our bounden duty to really look after our women much more better, and especially when there is a role for primary prevention that has to be taken on a war footing. We know that globally, cervical cancer is the fourth most common cancer in women, with around 66 to 44 new cases and 3,48,000 new cases in the world. In India, India actually accounts for 19% of global cervical cancer cases, but 23% of deaths, with an estimated 1,23,000 new cases and 67,500 deaths. So our age standardized incidence and mortality rates are very much higher than the global mean. And we know that every 5 minutes, nearly one person dies of HPV-related cancer. So human papilloma virus-related cancers are the second most common cancer in women in India after breast cancer. India, we know, I have already said, has a very high mortality, and HPV-related diseases and cancers pose a significant economic burden and psychological burden. So what are the HPV-related cancers? We know about cervical cancer, vaginal cancer, vulvar cancer, anal cancer, head and neck cancer, especially oropharyngeal, and in men, penile cancer. How does HPV lead to cervical cancer? Human papillomavirus infection is the most common viral infection in the reproductive tract. It spreads through contact with infected genital skin, mucous membrane, body fluids. So essentially through sexual contact, through oral sex, and also through fomites and non-sexual contact, and mother-to-child transmission is also seen. 70 to 90% of HPV infections are asymptomatic and resolve spontaneously within 1 to 2 years, a maximum of 3 years. Only persistent infection with high-risk types might progress to precancerous lesion. And about 5 to 10% of all infected women develop persistent infection. And we know about CIN 1, 2, and 3. CIN 1 and 2 might regress spontaneously, and the interval between the acquisition of HPV infection and progression to invasive carcinoma is very, very long, about 15 to 20 years or even longer. So what are the risk factors for progressive HPV disease? HPV type is very, very important. There are about 200 HPV types. Only about 15% are oncogenic. And immune status is also very, very important. Susceptibility is greater and progression time shorter in persons who are immunocompromised, HIV infected, or receiving immunosuppressive therapy. Co-infection with other sexually transmitted infections like herpes virus, chlamydia, and gonococcal infection. Parity, young age of initiation of coitus, coitarchy, and young age at first pregnancy. Long-term use of hormonal contraceptives, especially combined oral contraceptives, have been linked to a slightly increased risk of cervical cancer, but the risk decreases after stopping use and the overall risk remains low. Tobacco smoking, both active and passive. So the high risk types are 16, 18, 31, 33, 35, 39, 45, 51, 52, 56, 58, 59, 68, 73, and 82. Can these infections and diseases be treated? There is no treatment to eliminate HPV itself. It is a viral infection which is usually dealt with by the body's immune system. Then, how can we prevent HPV? Primary prevention is by getting vaccination against HPV. It is the most effective form of prevention, and education and awareness which helps to adopt good sexual health and practices also help to a great extent. So why does one need HPV vaccination? HPV vaccine prevents over 90% of cancers caused by HPV. And as I said earlier, prevents cervical cancer, vaginal, vulvar cancers in women, penile cancer in men, and cancers of tonsils, base of tongue, and oropharyngeal and anal region in both men and women. WHO has given us 3 key global targets to achieve by the year 2030. Only 5 years more. 90% of girls should be vaccinated with HPV vaccine by the age of 15. And we are yet to start on government side, although it has been there for nearly 2 years, a lot of talk about that. And 70% of screening our women with a high performance test by the age of 35, and the second one by the age of 45, and 90% of appropriate treatment for people identified with cervical disease. So we know that early vaccination is the key. And adolescents, why adolescents? Adolescents produce better immunity to fight HPV infection after vaccination as compared to young adults. So early vaccination helps provide higher reduction in lifetime risk of cervical cancer. Louis Pasteur said, when meditating over a disease, I never think of finding a remedy for it, but instead a means of preventing it. So we know prevention is the best thing what we have to do. And HPV vaccination before HPV exposure can give better protection and effectiveness. Always HPV seems to have a stigma. So since it seems to be mainly transmitted through sexual contact, so people are a bit reluctant to take HPV vaccination. And people also might ask why, when their children have not attained menarche, why it should be given. So immunity is best when it is given around 9 years. So 9 to 14-year-old girls will require only 2 doses of vaccine given 6 months apart, and girls aged 15 years and above require 3 doses of HPV vaccine. This is the same for boys also. And HPV vaccine prior to 15 years of age results in 2 times higher immune response against certain HPV-related cancers than after 15 years. So vaccination of boys is also important. And males remain susceptible to HPV infection throughout their life, and HPV transmission from females to males is higher than from males to females. And males also experience high rates of recurrent genital warts, and there is no routine HPV screening for males, and this increases the risk. When we have a routine HPV screening for women, we are cut a very sorry figure. But then males do not have that routine HPV screening too. So what about HPV vaccine history? It was first available in United States and was approved by FDA in 2006. Bivalent vaccine Cervarix was licensed by European Medicines Agency in 2007 and by FDA in 2009. Introduced in India in 2009 but withdrawn in 2022. The gender-neutral monovalent HPV vaccine, Gardasil 9, was licensed in India in 2018. Serum Institute of India launched the first made in India HPV vaccine for cervical cancer, which is also quadrivalent like the initial Gardasil vaccine, Cervavac, in January 2020. And Indian Ministry of Health and Family Welfare started preparations for the rollout of HPV vaccine for girls aged 9 to 14 years. We are 2 years down the line. Only certain pilot projects have been done, and the rollout is expected shortly. On February 1, 2024, Union Finance Minister of India announced in the budget inclusion of HPV vaccine for girls from 9 to 14 years in Universal Immunization Program. It is a recombinant DNA vaccine, and it does not contain virus particles, only virus-like particles. So it is non-infective. It does not contain live biological products, and Gardasil quadrivalent is active against HPV 6 and 11, which are essentially benign and cause troublesome anogenital warts, and 16 and 18, which is oncogenic and cause nearly 80 to 85% of HPV cancers. Nonovalent acts against HPV 6 and 11 benign, then against malignant types 16, 18, 31, 33, 45, 52, and 58. So has wider coverage. Cervavac is another quadrivalent vaccine, 6, 11, 16, and 18. What about its immunogenicity? It is highly immunogenic. Peak serum antibody titer are observed 4 weeks after the last dose. Then titer declines, but ultimately it stabilizes 12 to 18 months later. Serological response to vaccination is much stronger than the response after natural vaccination infection. That is the reason why we actively promote HPV vaccine, and high efficacy is observed in HPV naive population, that is people who are not exposed to HPV, and 90% against vulvar and vaginal lesions, and they also have high level protection against anogenital warts and precancerous lesions in susceptible men and women. So the duration of protection as of now is up to 12 years. It is said to be lifelong. So it covers HPV related cancers and is effective by 80 to 90%. And we have lot of trials, Future 1 and Future 2 with Gardasil, which prevented 98% of HPV 16 and 18 related high-grade cervical lesions. And in Australia and England, where both males and females are vaccinated through their universal immunization program for long, herd immunity has been achieved, and there is a decrease in HPV prevalence among both vaccinated and non-vaccinated women. So, is the vaccine safe? Generally well tolerated, no serious vaccine-related adverse experience. Main problem is redness, pain, and swelling, which is slightly more than other vaccines, headache and fever, but it is only of mild to moderate intensity. And syncope can be seen especially in young adolescent girls. So immunize them in a sitting position. Earlier, we used to give it in a lying position. Now we have to keep it at least in a sitting position and observe for 15 minutes. Well tolerated even by immunosuppressed and can be safely co-administered with TT, Tdap vaccine, and it should be given only in the Delta. And more than 250 million doses of HPV vaccines have been administered since 2007. This is a slide from FIGO, where they have clearly stated no serious adverse event has been directly linked to HPV vaccination, and frequency of anaphylaxis is 1 in 200,000 doses, similar to other vaccines. So this is an article from Guardian. We know it is effective. So why is there opposition to the HPV vaccine? There are a lot of vaccine bashers whom we see in the net. So progress in vaccination for girls has been slow in low and middle income countries. Less than 15% of girls had completed 3-dose HPV vaccination. One is the cost, second, vaccine supply, vaccine hesitancy and misinformation, and the stigma associated with HPV infection and cervical cancer. It is our bounden duty to dispel all these myths. So what are the contraindications? Severe allergic reaction to a vaccine component or following a prior dose, history of immediate hypersensitivity to yeast, and you have to be cautious when there is moderate or severe acute illness. So always better to defer it until symptoms improve. So now the HPV vaccines available in India are threefold. Quadrivalent and monovalent Gardasil by Merck, 9 to 45 years, and for boys, 9 to 15 years. Quadrivalent Cervaravac, and for boys and girls, 9 to 26 years. Vaccine to be stored at 2 to 8 degrees, administered immediately after taking out of refrigerator. 0.5 ml IM to be given only in deltoid region. So what are the special situations? Not recommended for use in pregnancy. If first dose is taken before pregnancy, the remaining can be completed per post-delivery. Inadvertent vaccination does not warrant medical termination of pregnancy. Lactating women can receive vaccine. Actually, we concentrate on all these postpartum women, as postpartum women are at higher risk of acquiring HPV. And opportunity, this is an opportunity for us to vaccinate after first delivery. Testing for HPV is not recommended before vaccination, and sexually active women and women with previous abnormal cervical cytology can receive the HPV vaccine. However, the benefits may be limited to protection against infection of HPV genotypes with which they have not been infected. We understand it is only a prophylactic vaccine, not a therapeutic one. Women who have been infected with vaccine HPV type and have cleared the cervical infection appear to have similar protective effects as those who are naive to the same vaccine. So dosage is 9 to 14 years, 2 doses 6 months apart, 15 to 26, 3 doses 0, 2 and 6 months, 26 to 45, 3 doses plus routine pap smear screening. For boys, 9 to 14 years, 2 doses 0 and 6 months, 15 to 26, 0, 2 and 6 months. And single dose is also advocated, of which I will talk about. And 1 or 2 doses from 9 to 20 years and 2 doses for 21 years above. This is actually a recommendation. I mean, it is not a final recommendation yet. And we have to administer the same vaccine for all doses when using a multi-dose schedule. And in a 3-dose schedule of HPV vaccine, the minimum interval are 4 weeks between the first and second, 12 weeks between the second and third dose, and 5 months between the first and third dose. So this single dose regime has been touted by WHO Strategic Advisory Group of Experts on Immunization. So seroconversion at the end of 24 months is found to be equivalent to multi-dose regime. It is an off-label option in girls and boys aged 9 to 20 years, offers program advantages, more efficient and affordable, and contribute to improved coverage. Immunocompromised
கொஞ்சம் சவுண்ட் கம்மி பண்ண தெரியுமா மீட்டிங் இருக்கு
will get the usual dose. So it is the recommendation has been to include HPV vaccination in the National Immunization Program of India. 140 countries are all following it. And surprisingly, Bhutan has opted for this earlier itself and gives it free of charge. And this, Rotary Club has been given free shots to teams against cervical cancers. They have really helped us out in eradication of polio, and now they are really helping us out with HPV-related cancers too. Next generation HPV vaccines focusing on high-valent vaccines with broad protection spectrum, and we have to evaluate the impact of HPV vaccination on all HPV-related cancers. We know that HPV causes 40% of head and neck cancers, but how far it is effective on those cancers, that also we have to really work it out. And a therapeutic vaccine for cancer treatment is also being tried out. HPV type 16E7 expressing lactobacillus-based vaccine for treatment of HPV 16 positive HSID. So this is the miracle study which is being conducted. And we have, so in future, probably we will be having a therapeutic vaccine. So HPV vaccine is an effective primary prevention for cervical cancer, anogenital warts, cancers of vagina, vulva, oropharynx, penis, and anus. Quadrivalent and monovalent vaccines are available. 2 doses in children from 9 to 14 years, 3 doses from the age of 15. Local reactions in the form of pain at injection site and syncope. Single dose advocated by WHO till the age of 20. Quadrivalent HPV vaccine for girls from 9 to 14 years has been included in Universal Immunization Schedule of India. Medical practitioners should motivate the eligible vaccinee to get vaccinated, and immunogenicity is better if given early. So I thank the Adolescent Committee for having given me an opportunity to share my thoughts on HPV vaccination. Thank you very much.
Thank you so much, Shanti ma'am, for the elaborate presentation of HPV vaccine in adolescents. I hope audience, whomsoever has listened to the content, in case you have any doubts, you can ping a message in the chat box so that we will have the discussion at the end of the session. Now moving on to our next session, which is going to be an interesting panel, and we have very two interesting moderators, Dr. Tamil Selvi M. Ma'am. We welcome you, ma'am. She has done her MBBS and DGO in Madurai Medical College. She has done her MD from Stanley Medical College, University First in DGO and MD. President of Trichy Society, OG Society 2024 and 2025. Her field of interest are in high-risk obstetrics, vaginal surgery and endoscopy. She is consultant in Arul Hospital, Trichy. She is a passionate trekker, trekked Western Ghats and Himalayas many times, and also has done Everest Base Camp this year. The next moderator for the panel session will be Dr. Davashri. Davashri ma'am is a consultant in SKS Hospital and clinical director of Vriksham by SKS Fertility Unit. She is a member MRCOG London, fellow of European Board of Obstetrics and Gynecology. She is heading the high-risk departments at SKS Hospital and PG Medical Institute, Salem. Fertility enhancing gynae and laparoscopic surgery and fertility specialist. She is a passionate mentor to teach doctors aspiring to become members of Royal College and the European Board. Over to you, ma'am. We welcome the moderators. Now I would like to request the moderators to introduce the panelists and proceed with the session.
Good evening, everyone. Is Davashri there?
Priya, Chitrakala, Davashri is there?
Share
Just
the screen. Share the screen. And I welcome Shanti madam. Just now she spoke and we don't need any introduction of Shanti madam. Everyone knows. Next slide, please. I invite Amala Devi madam, one more vibrant personality from Dindikal and key person in Tamil Nadu Federation of OG, and very active in giving the HPV vaccinations and everything. A great inspiring person. Next slide, please. Chandra Ponuswamy madam, one more senior member from Namakkal, gold medalist and running an IVF center in her district, and first IVF baby from her district, and one of the very nice person to move. Welcome, Chandra madam. Next slide. Sunita Samal, consultant obstetrician gynecologist, laparoscopic surgeon, Apollo Women's Hospital, Chennai. UG and PG teacher and DNB faculty, and special interest in minimally invasive gynec surgeries. She has many publications in national and international journals. Best paper award in 2015 and 17 AACOG. First prize in Foxy Zonal Quiz in 2002. And best research paper award in 2020 Oxycon. Organized many CMEs and workshops. Welcome, Dr. Sunita Samal. Next slide, please. Dr. Majabin, Assistant Professor at Sri Lalitambihe Medical College and Hospital, Madurai, Chennai. consultant OG and Hiba Specialty Hospital, Triplicane. UG and PG from RMCH, Annamalai University, and finished fellowship from World Laparoscopy Hospital, Delhi. Published many articles in national and international journals, and won many prizes. Welcome, Jabin. I think Dr. Ganga, Assistant Professor at ACS Medical College and Hospital, Chennai. MBBS from Perundurai and DGO from Thiruvananthapuram Government Medical College and MS from Madras Medical College. And she is interested in fertility and high-risk obstetrics. Welcome, panelist, and we like to learn from you. Davasri is there. She has to share the screen.
Yes, ma'am. Good evening, everyone. So let me share the screen, ma'am.
And this topic is very, very common topic we come across these case scenarios in our day-to-day practice. And we just want to highlight some points in the next 4 or 5 cases we are presenting.
Just a Ma'am, can you see the screen, ma'am?
Yes. All of you, please.
Yes, madam. It's visible.
Yes, we can see, madam.
So this is a very common cases, and many girls are brought to the gyneco PD with a complaint of discharge PV. And after the advertisement in all the FM radio, and nowadays there are many girls who are coming with the same complaints. Now we move on to the next slide. So she is 14-year-old girl brought by her mother, complaining of persistent white discharge for the past 3 months. The discharge is non-foul smelling, non-irritant. She has just attained menarche 6 months back. The mother is very worried that her doctor has some infection. The girl looks embarrassed and doesn't want to be examined. Do you need any further information? Ganga?
Yes, madam. So looking on to her history, she has just attained menarche 6 months back, but the character of discharge is not foul smelling and non-irritant too. So it's less likely of pathological discharge. It's more of a physiological. We need to ask about the quantity of a discharge, color of the discharge also. It is more, if it is not more towards the infective cause, can give reassurance for the patient to should look at the discharge, should examine the local area of the patient. More of should convince her, and we need to examine her locally. Then depending upon seeing the discharge character, we can come to a conclusion, madam.
We can get inputs from senior madams. Amala madam.
Oh, only just she had menopause, menarche only just 6 months ago. So it could be a hormonal, due to the hormonal thing,
Yes,
this
madam.
has happened, no? So nothing to worry about. You have to give counseling as well as reassurance. And if he has got any irritation or pain like that, then she should report to the doctor. Nothing to worry about this, because this seems to be a physiological.
Yes, madam. Absolutely right. Physiological. Any more input, and Davasri, go through.
So, like regarding the which time of the times we get the discharge, like whether it is a premenstrual or the mid-cycle discharge, that also will help, like to just to explain to the counsel the mother, like this is not anything pathological.
But
Yes,
yes, yeah, because since her inners get wetted and she feels very much embarrassed, so we have to rule out some worm infection from the gut infection and and it's definitely it's a scam. I mean, transplant of this physiological transformation of the inner zones, comma junction, and so we have to explain to them. And but symptomatically, we should give some placebos, and mainly she needs counseling. That's very important because she will be having some discharge, because everybody thinks why discharge means it's a malignancy, cancer. So that thing is there. So mainly counseling is important for her.
One more thing, her personal hygiene, what type of pads, napkins she's using also should be taught to her very clearly.
Okay, madam.
Some people, they may use cloths, no, not now. Of course, nowadays everybody started using sanitary napkins, but the personal hygiene also counts in the case of discharges for young girls. The changing of the pads and changing of the knicker, and all those things should be taught to them.
Okay.
And then moreover, these napkins also, this synthetic and all, they also produce some irritation.
Produce some irritation.
So, yeah, so we have to tell them if it is because of napkins, we should advise them to use cotton napkins, because all these synthetics.
Napkins, even they use the undergarments, that is also more important. Always you should encourage them to use the cotton one so that it will be helpful. And the small girls, they go to in the school also, what in the washroom, what kind of thing they are using, that is also very important. So I remember one of the patient mother was telling, girl's mother, her daughter never goes to washroom in the school itself. She'll come
Never
back home and do.
goes.
So those things are also very important. We need to, I think, discuss with the mother.
When we discuss with them, it is very important. They never go to the washroom. They never change the pads. I understand.
Yes.
Devashri?
Yes, ma'am. So as every one of the panelists have told that, all these points have been mentioned. So definitely examination is important, which we'll also have to have a thought about the foreign bodies. That also can be, so we should be little concerned if she has a recurrent complaint, we should be looking into it. And so as everybody said, this is physiological leukorrhea. And management, as we all rightly said, there's no medical management and assurance and counseling. So what is that we need to explain is all what we have said. So this is just a estrogen level rises that can cause all these changes. And it is normal to have a natural discharge, which can be a clear whitish, non-foul smelling, non-irritant. And reassurance, as we all said, it is not an infection or a disease. We just have to tell them, reassure, and no treatment is required unless she has itching, odor, or pain. So this we need to reassure her and send her. And as Chandra ma'am said, we need to advise her regarding simple, gentle hygiene, daily bathing, cotton undergarments, avoid tight clothing or harsh soaps, and I'll also tell them to avoid unnecessary vaginal washes or medications. So these are all the things that we need to tell her. This has been emphasized by even Amala ma'am. Thank you, ma'am.
Yeah,
So,
Dr. Tavasri told that unnecessary using of this vaginal douching. I have seen many patients, they do continuously some intervals, they do regularly use it for months together. So I used to explain them, once you use these medicated things months together, all the protective bacteria itself, it will wash away. So unless you ask them, they don't mention, because that they think it is just to make it a hygiene, we should use some medicated wash.
And moreover, I want to add something. Though we have to explain them, though it's not an infective etiology and all, we take this opportunity to tell them about vaccination and its high time. We should tell, though this is not concerned with that, but it is high time because it can boost up immunity. So we can take this opportunity to advise them all these things.
Yes, thank you, ma'am. And ma'am, Amala ma'am, can you please help us regarding the consent in adolescent? If they know, do we really have to take a consent to examine these kids who are less than 18 years?
So consent, you can get the consent from the parents, because she is always followed by her father or mother. So we will tell them that we are not going to do any invasive test for them. You are just going to examine the genitals Or if she is very scared that she doesn't want, then we can explain to the parents and get their consent, and better always not to treat without consent. No? It's a must always. Nowadays, because of the so many litigations, my child has been, she has been harassed by the doctor and something like that is happening nowadays, no? Better you always get a consent from the patient. Suppose if she is above 18, then we can just explain. A girl from a college, we can just explain to her,
Yes, madam.
and then we can do it. There is no harm in getting
Yes,
the
ma'am.
concern, no? But
Hmm.
absolutely, if it necessary means it is necessary to save us, not on the other side, whether the patient is willing or give her consent for that. To save us, we can get the consent from them.
Yes.
In addition to this
So,
getting
rightly said.
consent, yeah, in addition to that, we can have the mother nearby while examining. That's very, very important because
Well
many
taken, ma'am.
times we are
Yes.
seeing.
So, basically, yes, ma'am.
Yeah. Because many times, no, they are scared and they are very much frightened to remove their inners also. So that time mother will be of very much helpful and she can pacify her daughter. So that's more important.
Yes, ma'am. So basically, the parental consent is very important, as you all rightly said, under 18. But the thing is, she needs to understand that we are doing it for
Yes.
for examining to ensure that she's healthy, and it is not to doubt her. It is, we should never force her to examine, but then at least we can respect her autonomy, take an accent from that kid, and then go ahead with the examination. Thank you, ma'am. Yes, ma'am.
The second case scenario, a 15-year-old girl presents to the OPD with recurrent vaginal discharge and itching. She has been repeatedly given antibiotics and antifungals by various local doctors. What additional information do you need? Whether Shanti madam there?
Yeah.
Madam?
I'm there, Tabu. Sexual contact, we have to actually ask gender.
Okay.
That is very, very important. And young people are now diabetics. So that is also there. Or they are pre-diabetics. So all these things we have to ask. And even that girl, in the first case, only the mother was really anxious. The girl was perfectly all right. So that is a positive point for us, saying probably it is physiological. But here, when the girl comes with the complaint, then we have to take it into cognizance, and they keep on taking lot of antibiotics and antifungals, sometimes over the counter, or many times even we keep on giving all these things. So because of that, even all the, it can result in bacterial vagina. So many problems can be there. But most important in this is sexual contact. We have to ask.
Yes, ma'am. Majabin, you are not opening.
I was traveling, ma'am. Just now I reached my home.
Oh.
Just
It's
now I
okay.
reached.
Okay, so can I tell?
So do you want to add up any more things, Dr. Majabi?
So recurrent vaginal discharge and itching. What about the physical examination, ma'am?
Yes,
Here
that is
also
what was the first thing we wanted to know is a history. Then we'll go on to the examination. Is there anything else you want to know in the history?
Any associated symptoms? Any associated maturation complaints, bladder complaints?
Yes.
No, she doesn't have anything like that, ma'am.
Okay.
So mostly.
And what about the smell? And color of the discharge. These are very important things.
It is a mucoid or watery discharge.
Okay. Probably because of over treating of this patient, these patients can cause damage to the vulvar and vestibular epithelium. Even uh, so, see, without seeing, without the examination, physical examination, and the microscopic examination, we should not be giving treatment like antibiotics and antifungals.
Yes, and we have to ask about this any foreign bodies and whether she is using any menstrual cup or tampons, because she's 15 years and sometimes she might use tampons, forgotten tampons like that.
And sexual act.
Yes, all these things. Yes, ma'am.
Discussed.
Yes, that's what Shanti ma'am said. Sexual activity. Yes,
Sexual
that is a
activity.
very important thing.
And even if it is she herself is not sexual active, we can ask regarding the sexual abuse also, because sometimes they are like
Yes.
feel scared
Very
to
point
talk
well
about
taken.
this. Yeah. So
Yes,
sexual
Sunita.
abuse also you have to.
That is a very important point. Yes. And various medications, no. Many antifungal
Long-term
creams.
use of antibiotics can also produce this discharge, you know.
Also,
But there won't be itching, won't be there. Only thing,
yeah.
The
or
local
any
antifungal
hormones.
creams with the
Itching is
steroids, madam.
more.
Should also ask about the history of pulmonary tuberculosis. If it is a chronic, she's having so much of vaginal discharge for a prolonged period, I should also rule out TB.
Maybe probably we can. So with all these, she does not have, she just has a burn, a mild itch, no discharge, or sometimes she has a watery discharge. Whatever cream she is using, she finds a momentary relief. She wears tight wearing undercloths or jeans every day, and she does not have any vaginal douchings. She's not sexually active and changes pads once in the morning and once in the night. This is her practice. So do you need an examination after this?
Definitely.
But still, if the patient does not have all these symptoms, I think we need to locally examine the patient, like just local examination. We do not have to do a
Also, we can take the vaginal secretions for microscopy.
So we can just do the and sometimes like when they when they do the like vaginal saving and all that itself, it is causes some irritation and itching. So that also we have to take care. I think we need to just do an inspection of the vulva. That is very important.
And because of this recurrent
as
thing,
you rightly
we
said,
can use. Yeah, we can take the swabs and gentle swab. We can take for vaginal swab for culture and sensitivity.
Yes, ma'am. She's saying only minimal discharge. Yes, as you rightly said, definitely local examination will let us know whether she needs further investigations. So if it is foul smelling, irritant, bloody, or associated with the itching and pain, ulcers, yes, we need to do a swabs. Or basically to examine whether she has a foreign body or an infection, or definitely a sexual abuse, as madam said. So examination can be an external genital inspection only, preferably with a person along with us or the mother present. A speculum examination is not done, as we all know, and if it is definitely needed, then probably if we are suspecting a foreign body, then we have to take a consent, and under anesthesia, we can do it. Ma'am, Tamil ma'am?
Yes, external genital inspection is very, very important. That is, that has to be with the mother present or any female attender present. And any internal examination under anesthesia.
Yes, so
in addition,
the patient is having dry and excoriated skin and no abnormal discharge. What is our diagnosis?
So maybe patient is having like this tinea cruris, some tinea infection. That possibility is there because there is no abnormal discharge. So it may be due to this dermatological condition. Tinea infection also can be there.
Ma'am, no such things were identified when we examined. It was just an erythema and it was an excoriated skin. It was a dry and excoriated skin she had.
Okay, maybe she is itching too much. That is maybe the region she is having that excoriation. And it may be to any her undergarments what she is using because there is a lot of erythema you are telling.
Sometimes
She
no
has
sexual
tight-fitting
abuse.
underclothes. Synthetic
Yeah.
wear, synthetic
Yeah.
wears.
Because she is wearing tight undergarments every time. And
Fungal infection, madam.
Yeah.
Vaginal
Then,
erythema is more common in candidiasis.
but we cannot use rule out sexual abuse, because sometimes rubbing something like that also can produce a
Trauma,
type of,
minor trauma. Yes. Yes.
yeah.
And then
Yes.
we like the
But
direct sexual
yes, ma'am.
intercourse, that maybe also can happen.
Here, there was no, like with the history, she denies all those things, sexual abuse, everything has been denied.
no sexual activity, no sexual abuse, only tight undergarments, and she doesn't have any that is odor
Diabetes.
and any itching and any irritation like that. But she complains of discharge again and again, and when we see it is erythema and dry excoriated skin, but we don't find any abnormal discharge. Most probably the diagnosis will be
It's a non-infective.
it is non-infective vaginitis. Since we are dealing with the very young girls with the tight undergarments, it is a non-infective vaginitis. This is the point we like to discuss. So before giving any therapy, and we have to discuss with these patients. And what is the discussion? We have ruled out infection. Now it is only a non-infective. We are going to the counseling part of it now.
So mostly then you can just the lifestyle modification means you should advise
Yes.
her to like regarding her clothes, cotton clothes she has to use, regarding the pad also cotton pad, and not to use the tight undergarments, and again and this because they are all the school or college going. So morning once they're going, coming back home, it is a long time they're wearing the dress. So you can tell them to change the undergarments once they come home, and just washed with a normal water and normal soap. No need to use any medicated things or any douching, nothing is needed. So it is generally, basically, it's just to give the patient the general, just keep a general hygiene of the genital area.
Yes. As Sunita put it up correctly, and Amala madam also said, Chandra madam discussed, explain the normal physiology and menstrual hygiene and change of the sanitary pads and clean water washing, and always prefer the loose undergarments, at least at home. Synthetic clothing we have to avoid, and we have to change the pads and change clothes daily. Sometimes we used to advise these adolescent girls who comes with a discharge, you change your undergarments, buy a new 6 ones and you use it, and
Yes.
avoid.
At least during the periods,
Mm.
during menstruation, they can avoid these jeans pants, the sweat. And actually, if the sweat is there and the hair follicle gets infected, and sometimes that can get more complications. So better at least during that period, they can wear some loose pajamas or something like that. But nobody hears it. Yesterday we had a patient and she was full of folliculitis. So, and it was soaked, like water. If you soak it in a kerchief like that, the undergarment was soaked. So, more personal hygiene and wearing of clothes at least during this period, and washing every time. And but most of the girls, they don't go for even urination. They don't do in almost all the schools and everywhere in Tamil Nadu. I think it is like that. The same thing everybody is telling, because they feel that the toilet is not that good to use.
Yes,
So
in this contact dermatitis, contact vaginitis, and
yeah.
irritant vaginitis, these education and behavioral correction are very, very important. They have to manage the stress. Sometimes they come with many complaints, and they have a stress inside. And the sleep, nowadays there is no sleep at all because they always watch the screen. And dieting, nothing to say. They always go for the junk foods, and we have to educate in all the points. Previous slide. Lavashri. So
Yes, ma'am.
we like to get some points from the panel and how to differentiate between non-infective causes and recurrent candidiasis.
Definitely a fungal culture is needed to confirm the diagnosis for vulvovaginal candidiasis. So even with, so it's the patient with normal physical examination findings and no evidence of fungal elements by microscopy. There won't be any vulvovaginal candidiasis, so no need to give antifungals. And we have to exclude
Go to the slide. Yes. Yes, Madhavin, go ahead.
Yes, ma'am. We have to do a fungal culture. Either the blastospores or the mycelial forms can be seen if there is VVC, vulvovaginal candidiasis.
And even this infection also it can happen when they use repeated use of antibiotics. They use because each practitioner they go, they will give some antibiotic.
Antibiotics.
So that reduces the immunity. So that can cause also, and that would based on the type of discharge. So if it is like thick caudy discharge, then based on that we can think of whether it is candidate.
Color of the discharge, yes.
Yeah.
Without a culture, we can't diagnose a vulvovaginal candidiasis more.
Yes.
So the symptoms will be the candidate. We do a microscopy rather than culture.
Yeah. Oh, yes, ma'am.
So basically, clinical is more important. Definitely, the diagnosis is with, as Madam said, microscopy to see the fungal elements. But the thing is, intense itching will not be there in irritant or the non-infective vaginitis. Usually, she complains of mild burning irritation. That is the most important complaint. Watery or mucoid, whereas in this, they will have a thick curdy white. Usually, the odor is absent in case of recurrent candidiasis, which here it can be a slightly chemical smell can be there. But vulval, most of the times we see fissures with the women who has a recurrent candidiasis. Whereas here it can be an excoriated skin, and the response to the antifungals will be very good in case of candidiasis. But usually after that, once she stops, she might have again. Here for the non-infective, she will not have any response or a momentary relief might be there. And as we know, the microscopy pseudo elements will be there. So basically to identify the infection and treat if it is recurrent, we'll have to have a diagnosis. But once, if we know that it is non-infective, removing the irritants and maintaining the hygiene and avoiding over medication actually treats the condition. So this is the difference between the two. So thank you so much for the panel to have enlightened us this. Ma'am, can you move on to the next?
Darshi, you move.
Ma'am, I have a question regarding this.
Yes.
Whether any use of probiotic in these type of patients?
I think this
Amala ma'am
helps.
or Shanti ma'am. Chandra ma'am.
Yes.
Ma'am, Dr. Mahajabin has a question regarding the use of probiotics in young girls.
If it is irritant and all. No, I don't think it is of any use because irritant and all, remove the irritants, then she becomes better. When you suspect any worm infestation or gut infection, then only can use of a probiotic may be of use in such case. Otherwise, in yeast, fungus and all,
yes,
it is of no use.
Okay, ma'am.
Ma'am, there has been an article which says even for the candidiasis, probably addition of probiotics reduces the chances of recurrent candidiasis. There are few papers which say that, but definitely as Madam said, in case of infective cause, other than fungal, definite bacterial vaginosis, even TB, trichomoniasis, and all other bacterial, this has got, probiotics have got a role in getting back the lactobacillus and preventing future infection. You know, that is also for people have studied it for around 15 to 30 days, where they say using it continuously reduces the chance of the recurrent episodes. Ma'am, any other inputs, ma'am?
in case if you're using probiotic, how long we should give for bacterial vaginosis and other TB, ma'am?
Along with that of the antibiotics, 15 days to 30 days
15
is
days.
what has been
More
recommended.
than a
Yes,
day,
ma'am.
right?
At least 15 days.
Okay.
Yes, ma'am. Any other inputs, ma'am? Tamil, ma'am?
Yes, regarding the probiotic, it has to be used at least 15 days in the infective causes. That's what I want to stress.
Yes,
along with the antibiotics.
yes, ma'am. Thank you, ma'am.
So if you give antibiotic, then it will be a co-prescription. But
Yes, ma'am.
when we are not giving antibiotic, because there is a controversial view, I think so. Okay.
When it is approved trichomoniasis, approved bacterial
Chandra, ma'am, you're
vaginosis.
not audible clearly, ma'am. It is only for me or?
Yes, because I've got a function at my home and lot of guests are there. So I think it's, yeah, I can
Okay,
leave
ma'am.
the thing. No problem, no? Lot of commotion. That's all.
Okay, madam, no problem. Go ahead. Go ahead.
Okay.
So the point is, when it is trichomoniasis, when it is bacterial vaginosis, when we diagnosed it, we first treat it with antibiotics. When it is recurrent, we treat it with antibiotics and probiotics. That is the way we manage in our practice. And if it is a irritant vaginosis, there is no role for
One second,
probiotics at all.
Chandra ma'am, you keep your phone under mute only when you're answering. You unmute yourself, please. Then we all can hear the others. Ma'am,
Okay,
thank you, ma'am.
Navasri, we go to the next case. Navasri.
Yes, ma'am. Yes, ma'am. So this is the third scenario. This is a 16-year-old girl presents with a malodorous discharge and pelvic pain. On gentle counseling, she admits to have a consensual sexual contact with her boyfriend. She's worried about the confidentiality and doesn't want her parents to know. What do you think is a likely?
Most probable cause is trichomonas vaginitis.
It's a malodorous discharge with pelvic plane is more towards pelvic inflammatory disease.
Yes.
Okay.
As she is sexually, madam.
Chitrakala, one minute, Ganga. Chitrakala, can you mute Chandra, madam? Priya,
Ma'am, yes, ma'am.
can you mute Chandra, madam?
Yes, ma'am, done, ma'am.
Okay. Continue, Ganga. Sorry for interrupting. You can continue, Ganga.
That's what, madam. With this discharge and pelvic pain, and she is sexually active too. So most likely the diagnosis is pelvic inflammatory disease. Could be chlamydial. Cause could be anything. Chlamydia could also be a reason. Depending upon further details, we need to know what it could be. Can I get some more details, madam?
So malodorous discharge and pelvic pain, and she is sexually active, she is admitting, so it is sexually transmitted infections, okay? We have to think of all sexually transmitted infections here.
So as you rightly said, yes.
Yes, Davasri.
Associated conditions.
Yes. So what recommended evaluation? As madam said, we have to think of all the, just not chlamydia, but all the other things, even gonorrhea, TB, BV, and all other mixed infections. So what is a recommended evaluation for this girl? So what is it?
Go for a post speculum examination, history-wise, you should find it out whether she's having a multiple sexual partner or boyfriend is having multiple sexual partner. That is also very, very important, because I have seen few patients who gives like a history, they are having multiple partners, and even her partner is also having multiple sexual partners. And they tell also kindly do the STD test for them also. So in that case, that history is very, very important. And we'll do a local examination like a post-speculum examination to see the type of the discharge, like the color and the cervix, how it looks. And simultaneously, we can take a like a pap smear, 16-year-old girl, though it's sexually active, we can take. And along with that, you can take a high vaginal swab also, so that you will know like exactly what is the cause of infection. And if needed, if an PV bimanual examination, if she is having severe tenderness and all, maybe we need to do a like a one transvaginal ultrasound also may be needed based on the findings.
Approach also
She is
can
very
Okay.
much concerned about confidentiality.
the government hospitals, that is what we do. We have the 7 kits, and she will need an yellow, not only for herself, but also for her partner. Yellow, that
Thank you.
is,
Yes, madam. Yes, madam.
and we have to ensure compliance, that is, we have to counsel her properly and ensure compliance, and we should tell her that this can have adverse effects later, so you better have the drugs properly so that you are clear. That is very good.
Okay, madam.
Yes.
So the evaluation will be, Davashri, go through. I will
Yes.
just say general examination, local examination, investigations, and additional testing. Davashri, you
Yes, ma'am. So as very importantly, before examining her, we need to ask her whether she needs an immediate attention, for which as Dr. Ganga said, is it a PID? So this would need a definite alarming red flag symptoms, whether she has. We have to ask whether she has severe lower abdominal tenderness, fever, spikes of fever, discharge characteristics, which can be associated with PID, which we need to ask her. Then should be followed by a local examination. External genital examination is more than enough, but unless if we think definitely a pelvic examination is required, a local examination must be more than enough. And if we think it is PID, probably, as madam said, horny cell tenderness should be looked for, and investigations not only in high vaginal swab. If she is not willing to go for an examination for a high vaginal swab, we can ask her to take even a self swabs taken from the vagina. We can ask her to take, and that is especially for a microscopy, a culture, or a NAT. This is to identify chlamydia and gonorrhea. So if she is not ready for our examination, we can ask her an alternative of a self-taken swabs, or along with that, we can go for a wet mount to look for a TB and also for a clue cells and NAT. This is also for gonorrhea. And the vaginal pH can be looked for if possible, and a gram stain for a bacterial vaginosis. And let us not definitely forget, if she has been on a regular intercourse, urine pregnancy test is a must for her. And additional testing, as we all know, she needs serological testing with HIV, syphilis, and hepatitis B, but with an appropriate counseling and consent along with that of the partner. This is definitely required evaluation for a woman, for a girl who is sexually active. Yes, ma'am. Any points to be added?
anything to be added from the panel? This is one of the important slides, how to evaluate a young girl who is sexually active with a discharge. So we have to take a...
Yes,
Yes,
ma'am.
madam.
Serological testing.
Serological testing is to be done for any STI, right? For any patient who is coming with a sexually transmitted infection, we have to do serology. It's a must.
Yes.
Yes.
Even if they are, if they are
RPR.
not under the
So serological testing is important, and the wet mount for the TB and gram stain. It is very, very important. Urine pregnancy test is important. And then after that, the culture part comes. Taking a swab and going for the cultures. Okay. Now we move on to counseling of this girl. Counseling of this girl. And I need points from the panel, each and everyone.
Do we need to offer counseling for this girl?
No. Yeah, first of all, when we are counseling this patient, like at this such a young age, first, like regarding the sexual activity, you have to educate them, like what is the effect of having at a very younger age, this early way of sexual activity. It is more prone for cervical cancer and all those STDs. So we have to counsel them. First of all, we cannot tell them don't do because they won't listen to us. So most important is you have to tell them to use the barrier that will like it will act contraception
Safe
and
sexual
also,
practices.
yeah,
Okay.
safe sexual practices. That's very important. You have to tell them. And second thing is that they should avoid having a multiple sexual partners. And they should also find it out because we seeing in corporate, we used to see regular this kind of patients when the partner is also having multiple sexual partner. So you have to very carefully like that counsel the patient to take in confidence and talk to her because her future fertility, everything lies in this. So you have to
Important
yeah.
point.
Yeah.
We
So
have to
those
insist
things.
that your future fertility will get compromised. Yes.
Yes.
And
And
as
any any contraception?
Contraception, I think
Emergency contraception
Oh.
can be used.
Okay, madam. Okay, madam. Point taken. Okay.
nowadays
she's
they are using this emergency contraception as a regular contraception. Like they will take even the same cycle, they are taking some 2-3 doses and
Ma'am?
multiple. So yeah.
Ma'am,
So
can I just interfere one thing? 16-year-old you have given.
Talks.
Though out, men be out of the context, not STI, but 16-year-old, even consensual sex comes under POXO.
We have a question on
Please,
it,
for the
ma'am.
benefit of everyone here, we are talking about,
We
there
have
are
a
two
question on
different
it.
things.
We are covering it, ma'am.
Yes, ma'am. Yes, ma'am. Because I was just waiting if somebody is going to talk about that 16-year-old. That is why I interfered. Okay.
We are going to talk
Controversy is
about
never
it, ma'am.
settled. Now that we came to contraception, I thought now we ourselves are promoting sexual activity. Okay. Fine.
I just like to add a point, madam. As she is actively infected right now, better to avoid contraception, intercourse till she get treated with antibiotics, and also should counsel the partner. Her boyfriend to equally get treated with course of antibiotic for this moment for this episode.
Who knows that
treating a male partner is necessary only in trichomonas, not for every other case. But we have to counsel the patient and partner, both of them. We have to counsel them, and we need to evaluate this patient for treating a male partner.
Dr. Majabin, the partner needs to evaluation and then appropriate investigation. Without any investigation, TB can be treated, but he would need further investigations, either urethritis, all these things. He has to produce samples to identify chlamydia, gonorrhea, if she is found to have.
Yes, ma'am. But
so he also needs testing. He would need testing and then treat.
Yes, no. First, we'll be treating the female the partner. We'll be treating the patient first. If you're diagnosing the case, we can treat the partner, right now.
No.
Yes.
One thing I just want to add, even the legal husband doesn't come for any treatment or investigations.
Agreed, ma'am.
And the திருட்டு பொண்ணுகள்லாம் இவங்க வருவாங்கன்னு how can you expect that a boy?
Yes, they will not come, ma'am. Good point, ma'am.
He will never come.
He will never do also, ma'am. Even if
he will never show his face. Maybe this infection, she would have got it from him, even though she got it.
Madam, sorry to interfere, madam, but mostly they only bring them because they have an illegal contact. No, that boy only. But what these people will tell that my brother has come. But definitely he will come. Then we have to counsel her and tell if your partner is not treated, then you will repeatedly get this infection.
காதுலே வாங்க மாட்டாங்கம்மா இந்த பிள்ளைங்க. They will never listen. If they listen, they won't enter into this illegal contacts, இந்த ரிலேஷன்ஸே இருக்காது அவங்க கிட்ட. இந்த மாதிரி இதுல நிறைய கேர்ள்ஸ் they had been சும்மா அந்த ரொம்ப புவர் சோஷியோ எக்கனாமிக் குரூப்ஸ் mostly they get involved because of some monetary benefit or something like that. And not only for sex, nobody goes, no. There is lot of, with adolescent girls, we have to talk a very lot and then give them awareness. Awareness should be there for each and every girl who is in the colleges, or what happens when they get
Yes,
into that.
ma'am.
Some people say that we didn't do anything, but I am pregnant.
Yes, ma'am.
They don't know about the act of sex evil.
Yes, madam. All points about the counseling well taken, and we have to give a support also. It's the last
Yeah.
to be given. And we want
sorry, ma'am, Tamil ma'am, sorry to interrupt. 5 minutes more, ma'am.
okay.
8 minutes more.
So we move on to the treatment
So
of the PAD. Treatment part of PAD. She is diagnosed as pelvic inflammatory disease. Next slide. And what do we think?
Ma'am, let us, I think, ma'am, you can concise the, we'll go on to the consent, ma'am, the confidentiality. Ma'am, you can, Tamil Chelvi, ma'am. Can you please go? Yes, ma'am.
Confidentiality, we got to maintain it. We should not mention the name of the patient. We can give some number for them so that when the blood test comes, that also can give some ID numbers they can have. Because in MTPs, when we started practicing in 74 and all, only numbers will be there in the register. No names, no nothing. So like that we can confidentiality, but being she had come to you, you have to keep the confidentiality unless the unless the girl is very sick or she will get severe complication. Then it is our role to inform the parents also.
Amala madam, how it is possible? Because in the registration itself, they need the patient Aadhaar card and the name details. How it is possible to hide the name?
No, you have to have.
No, we have
you
got
have to-
previously we were doing it when we early days when we were doing MTPs. There will be some code number. There will be some
Yes.
code number. When there is 001 means it means some that names will be with us only. It won't be shown to the lab or anybody in the registers. Even to the government, it was not sent.
Yes.
No, no. What they are telling now, what they are telling, you have to maintain 2 registers.
Yeah.
One will be in the code, and that code we have to maintain it confidentially. Number 1 means or number 15 means this patient. Like that, they told us to maintain 2 registers.
For the, yes, ma'am. This is regarding, we are not talking about that confidentiality. This is about the law. No, what does the law say, or what is the approach if we find that the woman, that the girl is sexually active at the age of 16?
Definitely.
What are we
It means
supposed to do?
nowadays you should report to the police. See, below 18, if any woman is concerned with this sexual act, you should report to the immediate near police station.
Madam,
It is, they
without the name.
started doing it. They started doing it now. Below 18.
This is Amala ma'am. Amala ma'am. Yes, ma'am. Very rightly said, ma'am. The only thing which we wanted to emphasize today is less than 18 years. If we know that she has disclosed the sexual activity or she has a sexually transmitted infections, the doctor is legally bound to report under POSCO, either to the local police station or the special juvenile police unit. Within 24 hours of learning about the incident, it should be a written statement. A copy of it should be retained in our records. Or if the girl feels that if the parents know it and he might have a trouble at home, then we need to inform the child welfare company. So this is something which we should not forget when we know, because this is a clinical situation which is rising now. And so providing a non-judgmental empathetic care is in our hands, but we also have to save ourselves from the law. So we need to report this to the police.
Yes.
Tamil ma'am?
Definitely agree. Yes. We have to.
So less than 18 years, we have to get consent from the parent guardian.
Yes, ma'am.
In any invasive procedures. For STI testing, the doctor can use the discretion of the adolescent's best interest. But there are so many gray areas in this. Even the POXO, when you open the POXO and read, it says you should not mention the name of the girl in the complaint. Then how come we complain to the police station? I don't know. I don't know why. Because the recent CMON coordination meet was a big discussion, and we will discuss it later. But they said you just write daughter of so and so has come for. Then that man might have had 3 daughters. No. Then how come we don't mention the name of the girl? I don't. But as of now, we report to the police. That is the standing point. But I will put that law point in the group again. We move on to the next one.
Yes,
Savashri,
ma'am.
you
Yes,
don't have to.
Ma'am, I think we've got a very less time.
Intense itching, burning, gaudy discharge. Obvious. She has no prior similar episodes. Recently completed antibiotics for tonsillitis and vulval erythema, adherent plaques, and vaginal pH is 4.
Candidiasis.
Candidiasis.
This is a microscopic. Yeah.
Candidiasis.
We could able to see the hyphae and all. So, so it's a candidal.
Yes.
Yes.
So,
This is an acute uncomplicated vulvovaginal candidiasis.
Any predisposing factor in this?
Antibiotic.
Antibiotics. Antibiotics.
Okay. Any other predisposing factor for candidiasis?
Immunocompromised state.
Diabetics.
Sort of immunocompromised, diabetic with a low, poor hygiene.
Immunity is low in pregnancy.
Pregnancy.
Okay. Diabetes, contraceptive.
Tuberculosis also you have to like taken into account, like a low immunity also will be there. So that also can be a predisposing factor.
Immunocompromise. Yes.
How to diagnose?
How to diagnose?
It is a hyphae.
Basically, with the clinical diagnosis with curdy white discharge.
Also physical examination.
And with the microscopic examination with acidic vaginal pH with KOH subjecting to the, and also we could see the pseudo hyphens in the microscopes and spores.
Yes, ma'am. Right. So confirm. Basically, clinical examination is more than enough, but laboratory KOH, we would be able to see the hyphae. Do we need to do an examination to diagnose vulvovaginal candidiasis?
Yeah, already I think that.
Yes, we can do, ma'am.
To
rule out others.
Yes. Yes, to rule out the other causes of vaginitis.
Other causes of it.
Yes. How do we treat?
Antifungal, fluconazole or
fluconazole 150 milligram.
Yes. First line is single dose oral fluconazole, 150 milligram oral can be given. The second line can be topical azoles, which can be clotrimazole or meconazole. And symptomatic relief, sometimes they say even a steroid cream can be given. Dermatologists, they do recommend steroid creams for a momentary relief until the medications take over, and hygiene advice should be given. Any prevention strategies?
Yes, this predisposing factor should be avoided.
Yeah.
Yes, ma'am. Over treating antibiotics, antibiotics strategies.
Antibiotics and diabetics.
Here comes the role of probiotics.
Control of diabetes, and then
basically
stopping
with
of
the
antibiotics.
Yes, along with this treatment, then we can add probiotics here.
Yeah. Because you were taking antibiotics
ma'am.
for tonsillitis for a long time. So here I think that vaginal probiotics have this thing.
And a word about recurrent vulvovaginal candidiasis.
Sorry, ma'am.
Recurrent vulvovaginitis, we have to first think of predisposing factor.
For
Too many interruptions.
and usually it is that event. Initially we can give even fluconazole, which can be given every 3 days for about 6 months. It can be given. Nowadays we have other drugs like for all, along with control of sugar, then offending agents like tight clothing. These things also have to be taken care.
And treatment, madam, treatment of recurrent vulvovaginal candidiasis.
Nystatin 1 lakh international units. and boric acid. 600
250
milligram as a suppository.
milligram every 3 days it can be given, and that is initially it's given for 3 days.
Next
Then
slide.
it can be continued even for 6 months.
6.
But then now with itraconazole, which is much more effective, which can be given 1 milligram or 200 milligram for about 14 yearly helps. And we have also topical ones like fenticonazole. All these newer ones can be used where 2 doses have to be given along with oral.
Yes, madam. Nystatin pessaries for 14 days. 14 days. And oral fluconazole 3 times a week, then weekly up to 6 months. Actually, every week for 6 months. This is the suppressive prophylaxis because we get recurrent vulvovaginal candidiasis many times. And I think we have come to the end of the panel. And we like to have one take-home message from each of the panel members, starting from the seniors.
Ma'am, this last case, can I want to add only one thing, ma'am?
Yes, madam.
This vulvovaginal candidiasis. Another thing, one main thing we have to advise her personal hygiene. When we talk to these girls about personal hygiene, one thing is either they don't wash. You're able to hear, ma'am?
Yes,
Are
you
you
can.
able to
Yes,
see?
yes.
Yeah. Or there is too much of continuous washing
Yes, madam.
and vaginal douching. All these girls, no, adolescent age group, they think they keep on douching. And with that wet thing itself, they wear their undergarment and their pant on top of that, and that moistness is really responsible. So other than the medications, we have to advise them that they have to keep the area clean and they have to keep it dry also, not keep it moist always.
Keep
That's
and
one
dry.
thing. Another thing which recently what I'm doing, doing a paper trying to analyze this, madam. The usage of sanitary napkins, what we are using, no, all the disposable sanitary napkins have got a lot of microplastics which are coming out of it.
Yes,
These
yeah.
microplastics enter the vaginal microbe area. The entire vaginal microbiome gets altered. So this altered microbiome is one of the reasons for all these kind of PIDs, allergies, and future reproductive problems, preterm and all that. All
Yes,
this is they
yes.
are contemplating. Vagin, like how we are talking about a gut microbiome, they're talking a lot about vaginal microbiome. This is from the sanitary pads. So the advice would be also to switch over from sanitary pads into reusable cloth pads or into menstrual cups. That is another thing which we have to advise these adolescent girls when they come with recurrent infections. That's one thing I wanted to add, ma'am.
Okay, madam.
Ma'am, I
Point
need to
taken.
add one more point.
One thing, that is, if you should avoid sex before marriage. If at all, if you do, safe sex.
Yes. We
Okay,
have to talk to them about it.
okay, madam. Point
Yes.
taken.
Yeah, educate them and regarding awareness about menstrual hygiene. It's
Okay.
very, very important. Yeah.
Yes,
Okay,
ma'am.
madam.
And other than sexually active and foreign body also should be like the 1% is like the adolescent girl, they're having a persistent discharge, because I had a case when the girl has put like one groundnut along with
Yes.
the cells she has put inside into vagina, and patient is having discharge almost months, years together. Finally, we did a vaginoscopy and we found that, and it was a groundnut, almost like 3 centimeter, one full groundnut. So I think whenever there is a recurrent vaginal discharge, when you are not finding any cause, I think better we should think of
Foreign
foreign
bodies.
body also.
Foreign.
Yeah.
Foreign body.
Yes, go to
Yes.
this. Ganga,
All
you are-
charges are problematic. Take history patiently and try to differentiate vaginal discharge. Reassure them not unnecessary lot of and many of them use very fond of Dettol. Dettol,
Chitrakala, can you mute Chandra, madam?
all these are also
Sure, ma'am. Sure, ma'am.
Continue, Shanti, ma'am.
Shanti ma'am.
You can continue, Shanti, ma'am.
Dettol, you were on Dettol.
no. Oh,
said.
that's what
Using.
many times they are very finicky about being too clean. So using all sorts of things. So it
So,
comes on TV, they think then only they have clean. So all these things should be avoided. So small things will go a long way. Taking a proper history will really go a long way in avoiding unnecessary drugs.
Yes. Very well taken,
Almost
ma'am.
yes,
all points are
I need
discussed.
to,
We should
I need to
Proper,
add one more
proper
point.
evaluation,
Amen.
proper management, and then counseling and reassurance. She should be, as Chandra told, menstrual hygiene, and when she gets in discharge, how to go to whom she should contact, and what are the medicines she should take, what are the things she should avoid. As Tamil Selvi mentioned, no, all people, they used to wash with Dettol, that should not be used because that will kill the normal flora of the vagina also. So all these things should be ஒரு package மாதிரி should be taught to that girls whoever comes to us. What are the things they should do and what are the things they should not do.
Majabin, you are telling something?
Yes, ma'am. Washing from behind. That also, like while passing stools.
Okay. Point taken.
That also, yes, ma'am. And safe sex practice, as our seniors told, safe sex practice and personal hygiene is very, very necessary. And also, we
Okay.
should not overtreat a patient. In case if a patient comes with vaginal discharge, we should not start giving antibiotics or antifungals.
Okay. Thank you all panelists. And we like to emphasize about the physiological discharge. All discharges are not STDs. And examination of the vulva will help in the diagnosis definitely. And we should have the mother by the side. And empirical treatment, usually we avoid. And sexual activity, less than 18 years girls is there. But when she comes, we have the legal responsibility. I will share the slide in the group because we should not mention the name and all. Recurrent vulvovaginal candidiasis is one more area we have to be aware about the nystatin. Think about fluconazole resistant species. Davashri? I thank Davashri
Yes,
for
ma'am.
all beautiful slides. Thank you.
Ma'am, thank you so much for the opportunity and thank you so much, ma'am.
Thank you
Thank
so
you.
much, Tamil Selvi ma'am, and thank you so much, Davashri ma'am, for moderating this session so beautifully without any hindrance. Now I call upon our Oxy Secretary, Meena ma'am, to give the vote of thanks. Chitrakala, is Meena ma'am there?
Yes, madam is there, I think.
Okay.
Yes, ma'am is there. Meena ma'am?
Meena ma'am?
Hello, madam. It
Yes,
was an
ma'am. Vote
excellent
of
panel,
thanks.
madam. Thank you so much for the excellent panel, madam. And I thank Dr. Sampath madam, Vijay Lakshmi Gnanashekaran madam, Dr. Josephine Rosie, Dr. Shanti Gunasingh ma'am for having taken us through the HPV vaccination. And also excellent panel by Dr. Tamil Selvi madam and also all the expert panelists who have given valuable inputs, Dr. Amala Devi madam, Chandra Ponusa, young panelists. Thank you so much, panel madam. Thank you. We
Thank
had
you
lot
so
of
much,
take-home
one
points.
and all, ma'am. On
Thank
behalf
you.
of Oxy and TNFOG, thank you all so much for your active participation, ma'am. Thank you all so much, ma'am.
Yes.
Thank you,
Super good.
Joseph.
Thank you.
Thank you, Vicky ma'am.
Thank you,
Thank
madam.
Super good.
Thank you, ma'am.
Very
Thank
nice.
you,
Very
Shani.
nicely done. Thanks, everybody.
32 people has participated, I think. 32 or about 30. Most of them, there will be 10 or 15 now. At least it is 32 have registered.
Thank you, madam, for giving this opportunity.
Thank you, everybody. Thank
So
you.
basically, this is training of trainers, madam. So we have to convey this to the students, adolescent girls. That is what the education is all about.
Everyone knows all the points, but it is just a recap. Thank you.
Beautiful recap of everything. Thank you, Shanti ma'am. Thank you, Tamil Selvi ma'am, Davashri, Chandra ma'am, Amala ma'am, Sunita Samal, Majabin, Ganga, And without Jose, I can never survive. Thank you, Jose. Thanks, Meena. Thanks, Sampath, ma'am. Sunita, Samal, thank you so much.
Thank you.
And
Thank you,
thanks to all the participants. Bye-bye, everybody.
Bye.
Have happy
Thank you,
clinic
ma'am.
hour. Bye-bye.
Very active panel. Thank you. Thank you
Thank
so
you.
much.
Thank you, ma'am.
Thanks from you all. Thank you.
Thank you, ma'am. Thank you, ma'am.